Okay, let's unpack this. We're tackling a condition that's fascinating, critical, and frankly, a dermatological emergency.
Mm.
Today, we're doing a deep dive into erythroderma, which you might also know as exfoliative dermatitis.
Mm-hmm.
We've pulled together some really focused material, essentially high-yield revision points on this condition.
Yeah, the key stuff.
Exactly. Our mission is to guide you through these, extracting the absolute key nuggets so you get a clear, efficient understanding. This is the kind of knowledge that sticks, vital whether you're revising or facing a patient who might present like this.
Absolutely. And what's striking about erythroderma is just how severe a seemingly skin condition can actually be. It's much more than just a rash. It signals a significant disturbance across the whole body.
Definitely. And I think understanding what it is, fundamentally, that's our starting point.
So how do we define erythroderma?
At its core, it's defined as a severe, generalized inflammatory condition of the skin. Very widespread.
Right, severe and generalized. What's the key feature? The absolute key feature, the diagnostic hallmark, is diffuse erythema, that widespread, intense redness. And the definition is quite specific about the extent. It must involve more than 90% of the total body surface area.
More than 90%. Wow.
Yeah.
So we're not talking about a patch or even just like an arm or a leg. Imagine almost your entire body surface, head to toe, being bright red. That scale is a critical point.
That scale is the critical point for the definition.
Right. So once you recognize that massive redness, the next question is always, why is this happening? What causes it? It sounds like it's not just one thing.
No, definitely not. The etiology is quite varied, which is part of the challenge in managing it. Our information highlights several key categories to consider.
Okay, what are they?
Well, a major one and something clinically important to look for is drug reactions.
Drugs.
Yeah, even common medications can trigger this. Think antibiotics, particularly things like penicillins and sulfonamides, anticonvulsants, or non-steroidal anti-inflammatory drugs.
That's crucial to remember that asking about new medications is always step one.
Absolutely vital. But sometimes, even after a thorough investigation, you just can't find a specific cause that's categorized as idiopathic.
Right. Sometimes it's just unknown.
Exactly. It's important to acknowledge that happens. Other triggers include infections like HIV or hepatitis and certain fungal infections too.
Okay.
And interestingly, it can also be the final common pathway, if you like, of pre-existing inflammatory skin conditions.
That's like what?
Psoriasis is a classic example, as are severe cases of atopic dermatitis or contact dermatitis. These conditions can sometimes just escalate or transform into full-blown erythroderma.
So they flare up massively.
Precisely. And finally, certain malignancies can present this way, notably cutaneous T-cell lymphoma or leukemias.
Okay, malignancies too. Wow.
Yeah. So if we connect this back to that high-yield focus, seeing this widespread redness should immediately trigger a mental checklist, really, covering these potential causes, because identifying the trigger is absolutely fundamental to effective management. It's like solving a medical mystery. The skin is giving you this big red signal, but you have to figure out what underlying issue is actually setting it off.
That's a great way to frame it. It's often a symptom, not the primary disease itself.
Yeah. So who is more likely to develop this? Are there specific risk factors we should know?
Yes, certain individuals are definitely more susceptible. A prior history of underlying skin conditions, especially those we just mentioned like psoriasis or atopic dermatitis, that increases the risk.
Makes sense.
Also, a history of allergic reactions or sensitivities makes drug-induced erythroderma more likely.
Okay.
And perhaps unsurprisingly, individuals who are immunosuppressed, whether that's due to disease or medical treatment, they're at higher risk for developing erythroderma, particularly from, say, infectious causes or the progression of underlying conditions. So if you encounter that picture of diffuse redness, knowing these risk factors can help narrow down your differential diagnosis right from the start. Key clues.
Exactly. Key
Let's dig a little deeper then into how this happens under the skin. This is where it gets really interesting. What's the pathophysiology? What processes lead to this extreme generalized inflammation?
Okay, so the core problem involves a significant disruption of the skin's normal barrier function and a widespread immune dysregulation.
Barrier breakdown and immune chaos.
Pretty much. Think of your skin as a protective wall, right?
Yeah.
Or like that leaky roof analogy. When it's healthy, it keeps things out, keeps fluids and warmth in. In erythroderma, that wall breaks down on a massive scale. This barrier breakdown, combined with the body's immune system basically overreacting, that's the dysregulation, leads to a kind of vicious cycle of inflammation. The underlying trigger, whether it's a drug or infection, initiates this response, but the body's own immune system amplifies it across the entire skin surface, causing that diffuse erythema and damage. It's not just local, the immune system is essentially in overdrive everywhere.
Wow. And that broken barrier isn't just a visual issue, is it?
Not at all. It means the body is losing vital fluids, heat, nutrients, and it's incredibly susceptible to external threats like infection. It's why the skin problem quickly becomes a systemic one.
That really emphasizes the severity. Now, you mentioned the varied causes, and obviously other conditions can cause redness. What else could look like erythroderma that we absolutely need to distinguish it from? What are the key differential diagnoses?
Yeah, this is a critical point in diagnosis because several other serious conditions can present with widespread erythema. You need to have these on your radar to avoid misdiagnosis.
Okay, what should we be thinking of?
Well, the list includes conditions like toxic epidermal necrolysis, 10N, and Stevens-Johnson syndrome, SJS.
Ah, yes, 10N and SJS, very serious.
Very serious. They are often drug-induced, like some cases of erythroderma, but they typically involve significant blistering and, crucially, involvement of mucosal surfaces like the mouth, eyes, genitals. That often helps differentiate them.
Right, the mucosal involvement is key there. What else?
Other conditions to consider are psoriasis rubra pilaris, or PRP, and severe widespread seborrheic dermatitis.
Okay, PRP and sebderm.
Yeah. So even though they might look similar on the surface, widespread red skin, understanding these nuances and the associated features is absolutely key to getting the diagnosis right.
Absolutely critical. Moving on, who tends to get this and how common is it? Tell us a bit about the epidemiology.
Sure, our information confirms that erythroderma is relatively rare. You won't encounter it frequently in general practice, for example.
Okay, rare. Good to know.
However, it can affect people of all ages, from infants right through to the elderly.
All ages.
But it does appear to be more common in older adults and, as we discussed, in those with pre-existing skin conditions or compromised immune systems.
Right, those risk groups again.
Exactly. So while uncommon, being aware of these demographic trends helps maintain a higher index of suspicion in those more vulnerable populations.
Okay, let's make this more vivid. What does it actually look and feel like for the patient? Describe the clinical features you'd observe.
Right. The defining feature, the one that qualifies it as erythroderma, is that diffuse erythema covering over 90% of the body surface area. We keep coming back to that.
The 90% redness. Got it.
But it's definitely more than just red. The skin is typically intensely itchy. Pruritus is a major symptom, often debilitating. There's also usually significant scaling, although that often starts a bit later in the process. Patients complain of pain and warmth of the skin, too.
It sounds incredibly uncomfortable.
It really is. And beyond the skin itself, they often have systemic symptoms like fever, chills, and just a general feeling of being unwell or rundown malaise.
Systemic signs, too. Okay.
Yeah. Visually, the skin might also appear swollen, thickened, very tender to the touch. In severe cases, you might even see some blistering or oozing. And that desquamation you mentioned earlier, the shedding of large sheets of skin, that's a characteristic and often quite dramatic feature.
So let's paint a picture. Imagine a patient presenting like this. Almost entirely red, intensely itchy, maybe shivering with fever despite feeling hot. And their skin is visibly peeling away in sheets. It just paints a picture of someone who is profoundly unwell and uncomfortable.
That's a very accurate picture. It really drives home the severity.
So, faced with a patient like that, how do you figure out the specific cause and confirm the diagnosis? What investigations are necessary?
The diagnostic process really relies on putting together the whole picture. First, the patient's detailed clinical history, asking about onset, symptoms, recent medications, any new exposures, past medical history, especially skin conditions.
Right, the history first.
Then, a thorough physical examination. You need to assess the extent and characteristics of the skin involvement, check for those associated signs like scaling or tenderness, and also look for signs of systemic involvement or clues to underlying conditions.
Okay, history and exam. Then what?
Then investigations are crucial. They help confirm the diagnosis, assess the severity, and most importantly, they're part of hunting for that underlying trigger.
The detective work again.
Exactly. A key investigation is often a skin biopsy. This helps confirm erythroderma histologically, under the microscope, and it can provide crucial clues about the underlying cause, confirming an inflammatory process, maybe identifying malignant cells if that's the suspicion.
Biopsy is key. What about blood tests?
Standard laboratory blood tests are also essential. This includes a complete blood count, CBC, looking for signs of infection, or maybe blood dyscrasias linked to malignancy. Inflammatory markers like ESR and CRP will typically be elevated, reflecting that widespread inflammation.
High inflammatory markers make sense.
Yeah. And serological tests might be used to screen for infectious causes like HIV or hepatitis, or maybe even autoimmune conditions if they're suspected based on the history and presentation.
So the investigations aren't just confirming the skin problem. They're really part of that detective work to find the root cause.
Absolutely central to it.
And as our source material emphasizes, and you've said this is a dermatological emergency, what do you do? What's the management approach?
Recognizing it as an emergency is step one. That's crucial because these patients can deteriorate rapidly due to those complications we hinted at.
Okay, emergency mindset. What are the goals?
The primary goals are really threefold. First, identify and eliminate the trigger if possible. Second, control the widespread inflammation. And third, provide intensive supportive care to manage symptoms and prevent those complications.
Makes sense. What are the first steps?
Initial management involves immediate hospitalization, usually, for close monitoring. Monitoring vital signs frequently is essential temperature, heart rate, blood pressure, and crucial attention needs to be paid to fluid balance.
Fluid balance because of the leaky skin barrier.
Precisely. Because of that damaged barrier, patients lose significant amounts of fluid, electrolytes, and protein through their skin. This leads to dehydration and electrolyte imbalances, so careful monitoring and replacement is key.
Okay, hospitalization, vitals, fluids, then treatment.
The treatment strategy depends heavily on the suspected cause. If a drug is suspected, discontinuing it immediately is paramount. Obvious, but critical.
Stop the drug.
Right. Supportive skincare is also vital. Liberal use of emollients helps restore some barrier function, reduces scaling, and makes the patient more comfortable. Often, topical steroids are used carefully to help calm the local inflammation, but they're usually not enough on their own.
Not enough for such widespread inflammation.
Usually not. Given the widespread nature, systemic therapies are generally necessary. Corticosteroids, given orally or intravenously, are a mainstay to suppress that generalized immune response quickly.
Systemic steroids.
Yep.
Okay.
Other immunosuppressants might be used in specific cases, perhaps if steroids aren't working or contraindicated, or if it's linked to a specific autoimmune condition or malignancy where other agents are needed.
And what about really severe cases?
Severe cases, especially those with systemic involvement or developing complications like infection or organ dysfunction, they require intensive support. Sometimes that means admission to a high-dependency unit or even an intensive care setting.
Right. This can get very serious very quickly.
It absolutely can.
It sounds like a multi-pronged approach then. Address the cause, tackle the inflammation, and support the whole system. Given all this, what's the outlook for someone diagnosed with erythroderma? What's the prognosis?
The prognosis can vary quite significantly. It really depends heavily on several factors.
Okay, like what?
The underlying cause is probably the most important determinant. Erythroderma, due to a straightforward drug reaction that's caught early, generally has a much better prognosis once the drug is stopped.
That makes sense.
Whereas cases caused by an underlying malignancy or perhaps a severe systemic disease that's hard to control, naturally those have a more guarded prognosis.
Okay, cause is key. Anything else?
The severity of the erythroderma itself when it presents and how quickly the patient responds to treatment, those are also key factors.
So response to treatment matters too.
Definitely. And while many cases will resolve with appropriate management, especially when the trigger is identified and removed,
There's a but coming.
there is, unfortunately, severe or persistent cases, particularly those associated with malignancy or significant complications, can be fatal.
Fatal. How often?
The mortality rate quoted in the literature is significant, often cited as being between 20 to 40%.
20 to 40%. Wow.
Yeah, that figure really underscores why this isn't just a severe rash, but a potentially life-threatening condition requiring urgent expert attention.
Wow, 20 to 40% mortality. That is incredibly high for something that starts seemingly as a skin condition. It brings us directly to the potential complications you've mentioned. What are the major risks once that skin barrier is compromised and the body's in this highly inflamed state?
This is precisely why we keep emphasizing it being a dermatological emergency. The combination of the damaged skin barrier and the systemic inflammation leads to serious potential complications.
Okay, what sort of things?
Well, because the skin can't protect effectively, secondary infections are a major concern. Cellulitis, a bacterial infection of the skin and soft tissues, is common, and that can progress rapidly to sepsis, which is, of course, life-threatening.
Infection and sepsis, right?
Then there's the massive fluid loss through the skin, combined with an increased metabolic rate from all the inflammation. This leads to significant electrolyte imbalances, dehydration, and potentially severe nutritional deficiencies due to protein loss.
Fluid, electrolytes, nutrition. Big problems.
Huge problems. In severe cases, the systemic inflammation and these fluid shifts can lead to hypothermia. The body loses heat through the damaged skin, even if the patient feels hot or has a fever. There's a risk of septic shock from uncontrolled infection.
Septic shock.
And multi-organ failure affecting the heart, the kidneys, or the lungs.
Organ failure, too.
Yes. And our information specifically mentions ARDS, that's acute respiratory distress syndrome, a severe, life-threatening lung condition where fluid builds up in the air sacs, preventing oxygen from getting into the blood. It's a serious complication that can arise in critically ill patients with widespread inflammation like this.
ARDS. Goodness. These complications really highlight how quickly the localized skin issue can spiral into a full-blown systemic crisis affecting major organ systems.
Absolutely. It's a stark reminder of just how vital our skin is to overall health and maintaining balance, homeostasis.
Okay, so wrapping up this deep dive into erythroderma, we've covered its really dramatic definition that redness covering over 90% of the body surface. We explored the diverse range of causes, from drugs and infections to underlying skin conditions and even cancers, and the risk factors that make certain people more vulnerable.
Right.
We looked at the underlying pathophysiology, that breakdown of the skin barrier and the widespread immune dysregulation.
The leaky wall and the immune chaos.
Exactly. We discussed the crucial differential diagnoses to consider, what it actually looks and feels like for a patient, how investigations help pinpoint the cause.
Yeah, the detective work.
The urgent management required because it's a dermatological emergency, the variable but potentially severe prognosis, and critically, those life-threatening complications that can arise.
It truly is a condition where recognizing that pattern of widespread redness is just the first step. It kicks off a complex clinical puzzle that demands a systematic and, frankly, rapid approach to uncover and manage the underlying issue.
Absolutely. Which leads to a final thought, maybe. Given that erythroderma can stem from such incredibly diverse origins, from a potentially avoidable drug reaction all the way to an underlying serious malignancy, what does this teach us about the interconnectedness of the body's systems? How can a seemingly simple, albeit widespread skin symptom be a sign of such profound underlying disease? It's a powerful example of the body communicating distress, isn't it?
It really is a profound signal.
Something to think about. Now, for more free MSRA revision resources, definitely visit freemsra.com. And for the full premium revision toolkit, head over to passthemsra.com. Thanks for joining us for this deep dive.